Can you see my screen and am I clear to you?
Yes po, Doc.
Okay, so let us start with a prayer. In the name of the Father, of the Son, of the Holy Spirit. Amen. Direct, O God, we beseech thee all our actions by the holy inspiration and help us on by the gracious assistance, so that every prayer and work of ours may begin with thee and by thee be happily ended. Amen. My Father, Son, of the Holy Spirit. Amen. So this afternoon, our topic is preventive pediatrics. Okay. So we don't just diagnose diseases, we do not just manage diseases, but of course, primarily, we want to prevent diseases. Okay. So the objectives of this afternoon's topic lecture are the following: the goals of preventive pediatrics and the components of preventive pediatrics, which are your health supervision, and then the how to carry this out, as well as to educate on the value of preventive care. Furthermore, are the following objectives. So it's about counseling, it's about immunization, it's about routine visits, history taking, and physical examination. So what is preventive care? Okay, it's taking care of an apparently healthy child, as well as looking at the family. Okay, we foster strong relationships. We want to build this kind of relationship with the parents or the caregivers of the patient, and also with the adolescents. Okay, and we assist them in the provision of appropriate surveillance, screening, and it will also include early management of the diseases, okay? Because you also prevent complications and sequelae, okay, as part of secondary prevention. So the principles of health supervision are: one is health promotion, okay? Here we acknowledge the complex forces that impact health, such as familial, socioeconomic, educational, okay, developmental. So there are many forces that impact health, okay? And then there is this partnership. It requires an appreciation of the context of each child and family, okay, by communicating with parents, understanding their concerns, where they stand, okay, like financial constraints. We also educate them, okay? Like for example, when we want to vaccinate them, we have to educate them because there are a lot of misinformation and sharing of stories that are not facts, and they might believe this, okay? We acknowledge their strengths, okay? And if there are weaknesses, we try to also address that, okay? So the purpose of partnership is that we want the parents, the family, to trust us, okay? And we have to be truthful as well, okay, to be trusted. Communication is very important, okay? It is one of the main components for medical legal cases, okay? From miscommunication, okay? So how do we communicate properly? We listen. Okay? Listening attentively is one way of good communication, okay? We demonstrate respect. We show empathy, okay? These are ways of communicating properly with them, okay? And then when we ask questions, we ask open-ended questions, okay? We avoid being judgmental, okay? Like not asking, are you gay? No, like, diba, you have attended our Tuesday conferences before, diba? What are you in a relationship? Okay, so more of general, open-ended, and then let them share, and then inform you of that. Okay. We also establish relationship with children. For the continuity and coordination of care, this involves children with chronic condition that would need team care, referrals. Okay. So we coordinate care. For terminally ill, we refer to palliative care. Okay. So we also have to support the siblings of patients with chronic illness, with terminal illness, okay? We also need emotional support. And we can collaborate with community resources, okay? Like for rehab, okay? Preventive care covers regular scheduled visits. So these are the routine visits. And usually the purpose of routine visits early in infancy is immunization, or when you give vaccination, okay? But during these routine visits, we are also able to assess nutrition, okay? We are done with growth, okay? And one way to assess nutritional status is looking at the growth pattern, weight gain, increase in length or height, okay? And then we immunize, we give vaccines, we vaccinate infants and children. Or the initial visit could lead to a diagnosis, okay, based on history and physical examination, even if the parents do not have chief complaints, okay? And then most importantly as well is we assess the child's development. We look at the developmental milestones. We watch for, are there red flags? Okay, we do screen. We can have a tool in the clinic like the MCHAT, the modified checklist for autism in toddlers. So we can have this in our clinics and assess them, especially if there are parental concerns. So preventive care for children and youth offers greater opportunity for health cost savings, okay? Because, we know that an ounce of prevention is better than a pound of cure, okay? So how much is the cost of a complete doses of polio vaccine compared to management of polio disease plus the permanent sequela of poliomyelitis, okay? Now, these are the things that we need to accomplish when we see patients for health supervision visit or preventive care. As in every visit, there is history taking and physical examination. Then we screen. We'll discuss this further. We vaccinate. And then surveillance of developmental milestones. Okay, we look at what's appropriate for age when it comes to gross motor, fine motor, language, social skills. Okay, then anticipatory guidance. The infant can reach out for things, can put things in the mouth. So what are these? Okay. Our recent case is what? A 7-month-old who swallowed a safety pin. Diba, they have this pin in the clothes with anting-anting, quote unquote, okay? So anticipatory guidance. Sometimes even they put on bracelets and we advise them because sometimes they start biting it, okay? So these are preventable. And parents may not be aware of that, but that's part of our anticipatory guidance. So the anticipatory guidance is based on the developmental milestones of the infant and their age. For toddlers, for those who start to walk, we had cases of spillage of hot coffee because they pull on the tablecloth, okay, with a cup there by the parent, or a hot tea, okay. So they try to reach out, they climb, okay, they walk, they run, okay, so they hit their head, so we make the environment safer for them. The concerns are always addressed during each visit, okay? We ask the parents, aside from the chief complaint, do you have other concerns as to language, okay, as to some social skills? So we ask what's appropriate for a patient. If the patient is like a 12-month-old, does your child start to stand alone or walk with support or walk alone? Okay. Hindi pa po umuupo eh. Oh, that's a red flag. Okay. So we anticipate those things. Now, these are the 4 main tasks in a well child care visit. Okay. Disease detection, disease prevention, health promotion, and anticipatory guidance. And we'll go through it one by one. Okay, so disease detection. First is, this is accomplished by both surveillance and screening. So what do we mean by surveillance? It occurs in every visit to the clinic, okay? And we do history taking. We examine the infant, okay? So that's one way to detect disease, history taking. There was passage of worm, okay? History taking, look at the nutritional history. Is this patient at risk of iron deficiency anemia based on diet? Okay. Physical examination. Patient is pale. Okay. So patient has dry skin, itchy skin. So, and these are prone to secondary bacterial infections if not managed. So screening, on the other hand, during health visit is the performance of a more formal process using some form of tools. Examples, laboratory tests. You screen them for anemia if you use CBC and peripheral smear. Another formal process will be getting the blood pressure, okay, and checking for possible hypertension, okay. Usually, these are laboratory tests that screen for a disease. So one example of anemia surveillance is your history taking and physical examination. As I have said earlier, nutritional history, passage of worms, and then physical examination findings of probably pallor. While disease detection then is supplemented by anemia screening. Okay, we do CBC, okay? We check for hemoglobin, hematocrit. We look at peripheral smear for the presence of hypertonic, microcytic red cells. Okay. So let's get through some other screening tests in disease detection. So first is the newborn screening test. Okay. This is mandated by Republic Act 9288. Okay. And in this Republic Act, it states that prior to delivery of the newborn, the health practitioners inform the parents or the legal guardian about the newborn screening. So what's a newborn screening? It's a screening test for several metabolic congenital disorders. And we know that most babies with these metabolic disorders may initially look normal at birth. So they have the disease, they have the congenital anomaly, but they are apparently asymptomatic. And this can be screened and detected at birth. Okay. So it's ideally immediately done, actually 24 hours after birth, or not later than 3 days of age. Okay. So it's done by getting blood through heel prick method. And then there are few drops uh, placed on the filter paper, and this paper is dried and then sent to or picked up in the hospital and brought to the National Institutes of Health, UPPGH, for testing. So how about preterm neonates? How about low birth weight? How about sick neonates? How about those needing transfusion? Then samples may be taken before the 24th hour of life, before other interventions, okay? If it can be delayed until after 24 hours of life, and that's better. If not, it's taken earlier, and then a repeat screening should be collected on the 28th day of life for those who will have the test done before the 24th hour of life. Now, newborn screening detects the 6 metabolic disorders initially, okay? You have the congenital hypothyroidism and down the line, okay? Now, this newborn screening, the basic 6 diseases under newborn screening, these are part of the coverage for PhilHealth for babies delivered, okay, in a PhilHealth accredited institution. Now, in some cases, we have the expanded newborn screening, which in addition to these 6, includes these other metabolic congenital disorders. The amino acid disorders, like those in the urea cycle disorders, thalassemias, and fatty acid disorders. But these are not covered by PhilHealth. And if this will be done, they have an out-of-pocket additional, of course, expenses for that. But it's good to screen for this as well. We have a lot of cases also of thalassemias, or those with hemoglobinopathies, but it's part of the expanded. Now, what is very good with screening here is, for example, for congenital hypothyroidism, it would spell a big difference of being diagnosed early on. Now, this is screening. So once screened, they need further definitive tests. But once diagnosed, early intervention could mean the difference between a child having a normal IQ or a child who is mentally retarded, okay, because of late intervention. Another screening test for neonates will be the screening test for hearing, or the hearing screening test, also mandated by a Republic Act number 9709, or the Universal Newborn Hearing Screening and Intervention Act of 2009. It recommends screening not only for high-risk neonates, but even actually for all neonates, okay? Newborns up to less than 3 months of age, okay? And the screening test is what is called autoacoustic emission. Again, it's a screening test. So there is a need for further definitive tests if warranted. What if the infant fails the test, okay? In some institutions, they repeat the screening test. And if the repeat screening test still fails, then they would recommend a follow-up or a more definitive test. Another screening is your vision screening, of course, recommended by the Philippine Society of Pediatric Ophthalmology and Strabismus and the Philippine Academy of Ophthalmology. Screening from infancy until maturity of their visual system. Some would request for screening for error of refraction as well for children entering school. And the eye and vision screening test is the single most effective way of determining a child's eye health. Okay. So the screening method recommended based on age group are the following. Okay. So we have the fixes and follows test for younger infants, and we have the subjective and formal visual acuity testing for older children. So from birth, eye screening includes the following, okay? We check for steady eyes, okay? We check for white lustrous conjunctiva, clear cornea, non-droopy eyelids, okay? We check for pupillary reflex and the red-orange reflex, okay? These are the normal eye examination findings. And the clinical practice guidelines on routine eye examination as a screening tool for retinoblastoma recommends routine eye examination for leukocoria and strabismus, as these are the most common presenting signs of retinoblastoma. And now we'll proceed now to disease prevention. So when we talk about prevention, it can be classified as primary or secondary form of prevention. Okay. Primary prevention is prevention of the disease. How do we prevent disease? Okay, vaccination is one. Treatment of latent TB infection prevents TB disease because latent TB is different from TB disease. Okay. So these are ways of disease prevention, and it's primary because the disease is not yet there. You prevent the development of the disease as primary prevention. Secondary prevention aims to reduce the impact of disease that is already present. It's also a screening to identify diseases in the early stages, before onset of symptoms maybe, okay, or before or in the presence of the disease to prevent sequelae, okay? An example of primary prevention is vaccination. An example of secondary prevention is penicillin prophylaxis for patients with rheumatic fever to prevent development of rheumatic heart disease, okay? Or if a patient has RHD already, you give penicillin prophylaxis to prevent another recurrence or another episode of rheumatic heart disease, okay? We will have separate lecture on immunization as part of the disease prevention in child health. So the pediatrician needs individualized disease prevention strategies to the community as well as the specific family and patient. It depends on the needs, okay? Community concerns may be what? If there are increasing cases of polio or measles, well, the Department of Health intervenes by massive polio immunization. Okay, that's it. Or nationwide measles vaccination. Okay, so that's prevention if there are increasing cases in certain communities. So the third part of preventive care is health promotion and anticipatory guidance. Okay, so this distinguishes the well-child health supervision visit from all other encounters with the healthcare system. So we shift the focus to wellness and to strengthening family dynamics. Okay, what are they doing? Can this be improved? Okay, what's the family setup? Do they put do they put poisonous fluids in the bottles of Coke? Are these within reach of infants and children. Okay, so during infancy and early childhood, the focus is towards answering parents' questions as one of the most important priorities of the visit. Okay, so we ask for their concerns. Okay, maternal concerns are could be specific, and it's very important because they are the ones who see the children regularly, and they are the first one to observe probably some changes. Okay, the usual concerns are what? Language delay. Okay, they are they usually compare their child with the nephews, with the nieces, with their friends' children. Okay, so they have this point of comparison and having the same age and what their child has attained. Okay, so topics that are specific to individual child are based on their age. Okay, like infants, the concerns include teething or diarrhea when they shift milk. Okay, we look at the family situation. Uh, are the parents working abroad? Who is the caregiver? How many siblings? Okay, chronic health conditions of a sibling, of a parent, of a grandparent, and additional responsibilities for children maybe. Okay, again, parental concerns, and you look at the family milieu. Okay, are the parents, is the mother depressed? Okay, has there been a report of child abuse, substance abuse of parents? Okay, is the nutrition adequate? What's the usual diet? What are they giving? Okay, what's the socioeconomic status? So a lot of these factors would affect the well-being of the child that we care for. So also, of course, part of the health supervision is the assessment of nutrition. So we've discussed growth last week, and we know that we can indirectly assess nutrition through growth parameters, plotting this in the growth charts. Okay, we look at the physical activity, if any, and should have, okay, because of the use of gadgets. Sleep, how long do they sleep? Is it a, is it adequate based on age? Safety, again, and not just the physical growth, emotional and social as well. And we also look at the parental well-being. Other parents may have concerns with work, with their own health, with other problems, okay, and might not be providing the infant the proper reaction to the cues of their infants, okay. So preventive care is also about promoting family-centered care, okay. We have partnership with parents as it increases the ability to elicit parent concerns if you communicate with them, okay? Especially about the child's development and their learning and behavior. So as they sit with us in the clinic, we also observe the relationship of the child with the parent. Are they clingy? Are they aloof? Okay, are they avoiding the parent or the guardian? And we can start screening for developmental disorders like administering MCHAT-R, like the modified checklist for autism in toddlers, the revised one. These are just some simple questions being asked to the parent, and if it raises concerns, and we refer to DevPed. Now, as they grow older, the main concern with middle childhood and adolescent period are what? The privacy and confidentiality of topics and concerns, okay? So we initially talk with the parent being there, and then we ask permission in a nice way that we would like to talk with the adolescent privately without the parents, but if it's just the two of you, there should be a third person in the room, especially if the adolescent is the opposite sex of the doctor, okay? There has to be a third person. to prevent complaints later on. Okay. So attention to developing autonomy requires fostering clinician-patient relationship separate from clinician-child-family relationship, okay? Because of the need for privacy and confidentiality. So these are the 6 health behaviors that are most important in adolescent morbidity and mortality. For the adolescents, are they into a specific diet, okay, physical activity, sexual relationships, use of tobacco, alcohol, risk-taking behaviors that can contribute to unintentional injuries like driving, okay, and then violence as well. Moving on, let's now talk about the common topics of concern during routine health supervision visit. These are the topics, and we'll discuss some of them as we go along. So infants around 6 months of age will now have eruption of first tooth, and they present initially with discomfort, they become fretful, they bite, they drool, okay, some have low grade fever, but mostly are none, okay? So majority of them have no apparent difficulties, but some are brought in because of fever or irritability or fretfulness, okay? And the Philippine Pediatric Dental Society, okay, endorses what? That the first dental visit be at the time when first tooth erupts or no later than 12 months of age. By that time, 12 months, most children will have 6 teeth. Okay, diba? Age in months minus 6. So a 12-month-old will have about 6 teeth. Okay, and need a visit to the dentist for the first birthday. So the PPS policy statement on fluoride in the prevention of dental caries in children cites ways on how to prevent early childhood caries. Okay, so these are presented to you is a table on the recommendation on the use of fluoride toothpaste and the amount of fluoride parts per million. Okay, the frequency. Okay, topical fluoride treatment, on the other hand, prevents or reverse enamel demineralization. And this is done during the routine dental visits, okay? So those at moderate risk of having caries are recommended to have fluoride treatment more frequently, as in every 6 months. Now, I know pre-pandemic in some schools, they do it even as part of dental health in schools, okay? They have the dentist and the students go there twice a year for checkup and fluoride application. Okay, so other anticipatory measures in preventive dental care are guidance on oral hygiene and proper diet. You see, diet is still part of oral hygiene. Okay? Cleaning of teeth as soon as they erupt, dental floss to reduce interproximal caries, carcinogenicity of some food and beverage, prolonged bottle feeding or bottle feeding while sleeping, okay? And the mother's good oral hygiene as well. So you are familiar with how long should a child of a particular age group should sleep, okay? And we just don't say that they should sleep this long or this number of hours, okay? With the pandemic, diba, probably supposed to be the adolescents and the and the children should have better sleep because they don't have to leave early because of the traffic. But, I think the consequence of the pandemic is that they also sleep late or early in the morning. But in the US pre-pandemic, they in some states they start uh, class for adolescents at a later time, like 9 o'clock because of the importance of sleep. I hope that was addressed by that time adjustments, okay, and not spent for online gaming. So these are the basic principles of sleep hygiene for children. There should be a bedtime routine for children, okay? And what time should they wake up? It should be the same. That's recommended, whether it's a school day or a Sunday or a holiday. The timing of waking up should be the same so that they also sleep at the same time at night. But of course, it's not always possible. We have family occasions. Sometimes we have dinners with families and relatives and might end up sleeping late at times. We make the hour before bed a quiet time. So an hour or two before, no more gadgets, no more activities, no more physical activities, okay? You don't send the child to bed hungry, but they are at least fed about 3 hours before the sleeping time. They should spend time outside every day. Okay? That's part of a good sleep hygiene, that they spend time outside every day. Okay? They need exposure to the sunlight. They need vitamin D. Okay? The child's bedroom should not have their gadgets, their toys. It's meant for sleeping and relaxation. And please don't use the bedroom for time out or punishment. Okay? This should not be associated with such activities. Okay? Televisions and other gadgets outside of the room. So another common concern is toilet training. Okay? At 2 to 4 years of age, the child is developmentally ready to begin toilet training. The average is 3 years of age. Girls typically acquire bladder control earlier than boys. Bowel control typically is achieved before bladder control. But always remember that the key factor in toilet training is the readiness of the child. Like for example, they tell you, I want to pee. And you tell them, okay, hold on for a few seconds, let's go to the bathroom. That period of few seconds, if they are able to control it, that's one sign of readiness. So it's them communicating something and you addressing it directly and observing if capable already. So temper tantrums and breath holding spells are also common during the first year of life. It is their age-typical expressions of frustrations and anger. Okay? And parents are advised to attempt to avert defiance by giving child the choices that they want. Once a child begins to tantrum, the child can be given a timeout. So timeout means time out from any attention. Okay? So as long as a child is not going to hurt himself, okay. But if they're banging their head, of course, you have to do something. Don't leave them because they're going to hurt themselves. So the recommendation is 1 minute of time out for each year of age. So a 2-year-old will be given 2 minutes of time out. Now, when it comes to discipline, corporal punishment is not considered effective. Okay? As children habituate to repeated spanking, parents will have to spank even harder to get the next desired outcome or response, increasing the risk of serious injuries. Okay, so punishment may be in the form of issuing a negative stimulus or verbal reprimand, or even inflicting pain, okay, in order to reduce or eliminate an undesired behavior. Remember that sufficiently harsh punishment may inhibit undesired behaviors, but at a great psychological cost. The other and better discipline strategies recommended are like countdown. There must be clear communication of rules, and the rules must be age appropriate. Okay. Maybe frequent approvals of positive behaviors. To start with, we should set boundaries within reason, and that these are developmentally appropriate. Okay. It's okay to let them cry. Okay. It's better to identify the emotion. I know you are angry. I know you are mad. I know you are disappointed. Okay. Maybe we have to empathize with them, and we have to identify facts. You threw the shoe to me. It hurt. It hit my face. We could talk about this, okay? And I do not want you to do it again. So clear, simple, uh, directing to their actions and not to the person. Take note that the cornerstones for effective discipline are consistency. Okay, that's always number one. It's not, no, you are not allowed to use the gadget during meal, and then tomorrow loud. So they get confused. So if it's inconsistent, they won't follow. And they will try to break the rule, and we just have to be consistent with following it. Okay. Open communication is important. Talk with the child at a level, no pointing. Okay. There's mutual respect. We listen. We listen to their reason. Okay. We listen to their side of the story. So verbal reprimand may become abusive when reprimands do not address undesired behavior, but rather assault the character of the child. Okay? We do not say bobo ka, diba? When they just spilled something from the cup. Okay? There is growing evidence, of course, that growing evidence demonstrates the impact of media, particularly gadgets, television, on the health of the children. And there are untoward effects in terms of violence and aggressive behaviors. You notice children have are impatient. They're impatient. Why? Because with the gadgets, with just a click, they get what they want to see. They hear what they want to hear. And so if you do ask them to stay put or to wait, they're impatient. Okay? That's commonly observed among those who are gadget dependents. The American Academy of Pediatrics recommends that parents prioritize creative, unplugged playtime for infants and toddlers, although they had relaxed during the pandemic because schools are online, okay, and parents are working, and so it had relaxed in a while. But still, if you can take them off screen, would also entail that the parents spend time with them and they are busy, okay? If the child is under the care of a helper, it will be convenient for this caregiver to just give the child a gadget and she can do anything she wants to. Walang babantayan, walang pipigilan, okay? So it's important to engage them in activities, okay? Like taekwondo, swimming, okay? And parents spend time with their children to accompany them. And it's expensive as well, probably. But these are the convenient and easy ways to take them off gadgets, okay? They have to engage in something else. Parents of young children should watch media with their child to help children understand what they are seeing. Because if they're on the gadgets, you take time away from physical interaction. Okay? That's the price of gadgets on in front of them. Less time to interact, less uh, less time to hug, to squeeze the child, to talk with them. For school age children and adolescents, the idea is to balance media use with other healthy behaviors. So place consistent limits on the time spent, okay, and make sure that the media does not take place of adequate sleep and other behaviors essential to health. So like we designate meal media-free times, like during meals, no gadgets on the table. 1 hour before sleep, no more gadgets. Others would advocate only use of gadgets on weekends. Okay. No gadgets in the bedroom. Okay. And we should, for older children, we should communicate with them about online citizenship. Okay. How it is to safely go through online games and sites. That's citizenship. Okay. What is safe? Not just what is safe for you, but how to respect others as well online. Okay. But you do offline should also be done online when it comes to respect. Okay. What sites to go through. Okay. Violence permeates the lives of children daily. It can come in different forms, like the following. Okay. In other countries, we know that access to firearms and legal ownership have the price of mass shootings. Diba? We know that. We have substance abuse, okay, and other forms of violence. Verbal, physical, emotional. Okay. RA 7610 for the Anti-Child Abuse Law mandates that the head of any public or private hospital, medical clinic, and similar institutions, as well as attending pediatricians and nurses, shall report either orally or in writing to any of this. If in the treatment of a child, the child appears to have suffered abuse, and this should be reported within 48 hours from the knowledge of the scene. We now have, as well in the hospitals, Women's Child's Desk, as well, or WCPU unit, okay, in the hospital. Some hospitals have that. Some hospitals are required to have that, depending on the level of the hospitals, okay? And we are obliged to report them. Remember that some of the abusers are the parents, guardian, and the child should not be sent home with them if they are the proponent. This table is to show you the recommended anticipatory guidance topics for prevention of violence against children. Okay, it starts at birth with domestic violence. Okay, shaken baby syndrome, it may be unintentional or intentional, but education is important here. If it's unintentional, they should be made aware that it could be fatal. Okay, as they grow older, okay, bullying can occur at an earlier age, of course, school age, especially with access to gadgets. And that's it. As an initiative, so as an initiative in the prevention of child abuse, The World Health Organization has coined INSPIRE, which means the following, okay? To prevent child abuse, okay? So another concern is tobacco use, okay? And parental disapproval may prevent adolescents from becoming smokers, okay? It's a very strong statement, okay? And this is evidence-based, okay? So we don't just let them. This is one act we're in. We don't say you face the consequences of that, okay? Because your disapproval plays an important role in the prevention of them becoming smokers. So based on the FNRI study on the statistics of overweight and obesity, prevalence among children is about 5%, while among teenagers it is 8%. And the survey shows that children who belong to wealthier families tend to be more overweight and obese than poorer households. Okay? Early on, children must be taught the value of eating healthy foods. And how is this going to happen? Parents should set example. Parents should also have eating healthy eating habits, okay? Especially for young children. What food do they eat at home? It's what you buy. It's what you put in the ref. What's in your ref. Sodas. Okay, so these are it. Okay. So we set by example. Okay, for the second part, we can have a 5-minute break. Okay, we'll have a break first. Then walk around. We're back. Hello. Okay, so we'll continue my lecture. Ang bilis lang ng 10 minutes. Okay, so other preventive healthcare prevention recommendations, okay? AAP strongly recommends that pediatricians advise parents about the importance of reading aloud to their children during the first years of life, okay? Research has shown that this helps develop language and literacy skills, thus making children ready to learn and read in school. So we read aloud to them, and we also read books that they will observe us and imitate us. Okay. Prenatal education may be done through a structured mother's class or face-to-face counseling with a healthcare professional. So this is done with the OB/GYN department in collaboration with them, because these are still pregnant women. So our contact with the parents usually are at birth, okay, but we can collaborate with such activities, okay? Education and counseling must include the following areas of concern, okay? Breastfeeding, newborn care, and anticipatory guidance, okay? So when it when we talk of prenatal education, we talk of the mother who is pregnant as well as adolescents, okay, who are of course not pregnant. We talk of prevention of smoking, alcohol intake, and exposure to teratogens, okay. The OBGYN recommends tetanus toxoid immunization and supplementation with folic acid. Remember that we do not just supplement with folic acid when they become pregnant. They become pregnant, they become aware of it at 12 weeks age of gestation, and by then CNS development had reached its maximum development, and therefore it's too late to start folic acid once you know you are pregnant. Hence, folic acid supplementation to prevent neural tube defects is recommended for all women of childbearing age, because sometimes pregnancy becomes an outcome of an accident, okay? So unprepared, and therefore folic acid supplementation may be late already. So it is recommended for all women of childbearing age. Other recommended procedures done during the infant's birth may be explained during the prenatal visits, like the importance of course, of breastfeeding, the importance of early rooming in for a successful breastfeeding, screening tests, immunizations at birth. Okay, these are all should be educated, should be relayed to the mothers. Okay, the importance of all of this, so they are not surprised or caught off guard on what am I going to sign consent for? Will this cause additional burden to us? Okay, when in fact all of this, the newborn screening, hearing screening, BCG, and Hep B are part of the PhilHealth package, okay, in the hospitals. So it's free, okay? And colostrum, the importance of it being the first perfect food for newborn, and therefore latching on and breastfeeding must be initiated during the first 30 minutes to 1 hour after giving birth, okay? And so we should start counseling regarding breastfeeding even during the prenatal period. Mothers must be encouraged to exclusively breastfeed up to 6 months and continued on up to 2 years and beyond after introduction of complementary food. Remember that PhilHealth accreditation is issued to baby-friendly hospitals. Why will you go to a non-accredited PhilHealth hospital. That would mean total expenses will be out of pocket. So you go to a PhilHealth accredited hospital to get the benefits. And they would require you to breastfeed. And you cannot buy infant formula in the hospital pharmacy. Okay? Now, for those who opt not to breastfeed because we cannot force them, the hospital has a responsibility to ask for a waiver of the parent that they refuse to give breast milk and will opt infant formula. And they sign that paper waiver. That's a legal document for the hospital who is PhilHealth accredited. And attached with it will be the benefits of breastfeeding. Okay. They are aware of what they are depriving their neonate of. So safe, adequate, timely, and properly fed complementary feeding is introduced at 6 months of age, while breastfeeding is being continued. Okay. So we have this pyramid as a guide. Of course, we cannot quantify the exact amount of food and nutrients that the child eats, but an approximation would be a good guide. And then we can now have an idea of, is the child eating 50% of the recommended amount of the recommended food groups, okay? So we can quantify in that way. So this is crafted by the PSPGN, the Philippine Society of Pediatric Gastroenterology and Nutrition, okay? As a guide for physicians and parents in providing healthy diets for children. So postnatal education now, every infant must be totally evaluated at birth and monitored daily until discharged from the hospital. And the optimal time of discharge will be when the infant is feeding well, the infant has passed stool and urine, the infant is thermoregulated, okay? Those are the basis for early discharge. And usually these are observed within 24 hours from birth, especially for those delivered via NSD. Some are being sent home the following day. For newborns discharged less than 48 hours after delivery, they have to be examined again within 48 hours from discharge, okay? This will address issues encountered upon going home, because the hospital setting is different from the house, from the home. There could be no support system in the home. Mothers will encounter additional medical concerns like pain, okay, and maybe reasons for discontinuing breastfeeding. That's why we want to see them within 48 hours from early discharge, okay? While those discharged after 48 hours after birth without any concerns may be seen at 2 weeks of age. So these are some of the things that we need to check on babies' follow-up if you discharge them less than 48 hours specifically. Hydration is very important. Even if the mother is breastfeeding, is she giving adequate amount? We can't measure it if the mother is directly breastfeeding. So we have to assess it through signs of dehydration. What time did the baby urinate? When was the last bowel movement? Is the baby always rooting? Is the baby still crying after feeding? So these are the hunger cues that we want to observe. Upon examination, what is the weight of the neonate? Is the weight loss beyond what is physiologically acceptable for age? Okay. So these are the things that we check on early follow-up. So history taking, physical examination still remain to be the most powerful instruments available for us pediatricians in identifying concerns that may need monitoring and referral. You know, when you examine adolescents, some are wearing sweaters or jackets, okay? If they're wearing a shirt inside, we ask them to remove their sweater. Some will have suicidal marks that are hidden, okay? So a complete physical examination would need physical assessment of areas where there could have been signs of previous attempts, okay? So without you thinking that there was a history of attempt, sometimes you cannot elicit that in the history. So a physical examination may reveal that. So please examine them without their sweaters or jackets, okay? Risk assessment and screening will include use of heads or heads first for a complete history taking of adolescent patients, okay? And this must be done to each adolescent visiting the clinic. Okay? I won't go through each of this anymore. So approach to a thorough physical exam and interpretation of findings must be age appropriate. Okay? We respect the older child's privacy. We minimize the child's discomfort when doing physical examination. Okay. For adolescents, okay, we check for scoliosis. Sometimes you can observe this while weighing them, looking at their back. Sometimes you can see that the right shoulder is higher than the left, okay? Sometimes the chest, the front, it's like that the one breast is more prominent than the other one. So these are the observations seen in those with scoliosis, especially those who are about to reach their height velocity, they will have probably scoliosis. So inspection of the genitalia would require permission and a third party being in the room to avoid medical legal issues as well. For complaints, okay, that's a way of protecting yourself also. So when we screen adolescents, we screen for hemoglobin, for CBC, or at least hemoglobin hematocrit at every stage, early, middle, late, urinalysis on first encounter. This can be done initially through history taking. Okay, again, the questions should be non-judgmental. Okay, like reacting to, ang dami mo na naging partners. So not like that. So again, there are guide questions so as not to intimidate them. Okay. Screening for this and having found them to be positive would also necessitate referral and screening for HIV testing. Okay. So developmental, psychosocial, and other chronic disease issues may require frequent counseling and treatment, okay? As well as counseling of family members and other siblings who are being deprived of attention because of another sibling with chronic disease, who are being deprived of opportunities to engage in other activities because of additional health-related costs for the family. Okay. The World Health Organization growth standards are used as reference standard for weight, height, and head circumference. And interpretation is based on the z-scores or the standard deviation scores and not on the percentile scores. So we refrain from using, you belong to the 95th percentile or the 50th percentile. We refer to the z-score. Z-score of 0 is acceptable average. So routine blood pressure monitoring is recommended for children beginning 3 years of age. Every well-child visit. However, it's taken for any child who came in because of an illness, regardless of age. Okay, if the child is younger than 3, but ill, could be dengue, could be UTI, meningitis, there's a need to get the blood pressure. not because the child is not yet 3 years of age, okay? 3 years of age for healthy well visit, okay? So the definition of elevated blood pressure is greater than 90th percentile to less than 95th percentile, whichever is lower, okay? And for 13 years and up, this is the reference. We recommend age-appropriate physical activities for children and adolescents for a minimum of 60 minutes daily, okay? And this is moderate physical activities, okay? So, who meet these requirements? Maybe those who are varsity players or those who participate in activities like swimming, okay, taekwondo, basketball, football. But for one who is just staying at home, this may be difficult to achieve, but this is part of the healthy diet. Okay, healthy nutrition includes physical activities. So these are some physical activities we used to enjoy, but rarely see nowadays, still being enjoyed by those in the low socioeconomic status because of absence of gadgets that they cannot afford. So now they reap the benefits of that one, but they could also be suffering from poor nutrition and lack of opportunity for good education. Iron deficiency anemia is associated with cognitive and psychomotor abnormalities in children. And at risk are those with past or family history of anemia, okay? Why? Maybe those with siblings with IDA, iron deficiency anemia, may really have some family dynamics concerns about diet or nutrition, choices of food and activities, okay, that put the other siblings also at the same risk as the older siblings. So the Philippine Society of Pediatric Hematology and Blood Transfusion recommends a CBC at least once between 6 to 24 months of age, 2 to 6 years, and 10 to 19 years of age. Okay? High risk for iron deficiency anemia and good to be screened and to intervene. There are only 2 recommendations by the Department on Health on supplementation with minerals and vitamins. The first is iron supplementation. And this is the recommended one. For infants 6 months and older, we give 15 milligrams of elemental iron. Okay. Some preparation is 15 milligrams per 1 ml. So we give 1 ml. This amount should be equivalent to 15 milligrams. Okay. So it's not a specific amount, 0.6 ml. Because there are drops containing 15 milligrams per ml. There are preparations that contain 7.5 milligrams per ml, and that would mean 2 ml is required to get the 15 milligram recommendation. So we focus on the milligram of elemental iron required, not the volume, okay? So for low birth weight infant, we give 7.5 milligrams. For older children, we give 30 milligrams daily, okay? And even for older children, with anemia, of course, a higher amount based on weight, okay? And adolescent girls, at least 60 milligrams. And look at what we recommend for adolescents. Not just iron, but folic acid, because they're already childbearing age, okay? And they must be given this daily, okay? And the only vitamin that is also recommended for supplementation, the other one is vitamin A, okay? We give it beginning 6 months of age. and then between 1 year to 5 years of age. Okay, especially in health centers where we have the low socioeconomic strata following up, and we know that the concern there is the diet. Okay, but in private practice, if the diet is varied and adequate, okay, usually they don't give this anymore in private practice. So the Department of Health Administrative Order 2015-0054 is the revised guidelines on deworming, mass drug administration, and management of adverse events, okay, following deworming. It's recommended for all children 1 to 12 years of age. So we give this routinely, okay? We give it every 6 months on full stomach, okay? In my practice, I always give mebendazole as 500 milligrams single dose every 6 months, okay? So that's routine, okay? Remember that we cannot, even if it's routine, we don't give it to this group of children with high risk for adverse events. Severe malnourished children, we do not deworm them. Initially, we manage them for severe malnutrition. Patients with high-grade fever, with profuse diarrhea, with abdominal pain, with previous hypersensitivity, with serious illnesses. We defer giving of mebendazole or albendazole. Red flag signs for atopy, okay, would be any child with a family history, okay, of any of this who presents with recurrent or persistent symptoms of one or more of the following. Should be closely monitored, investigated, or referred when warranted, especially if they don't respond to treatment. Remember that allergies manifest in many ways, via skin, GI, respiratory system. Another part of preventive pediatrics is tuberculin testing, or the purified protein derivative, okay, 5TU, okay. Why is it part of preventive pediatrics? Okay, if you test positive with exposure but is asymptomatic, then you are diagnosed to have the infection, but not the disease yet. And treatment of infection or latent TB infection can prevent development of TB disease. So these are the ones who are at risk. Why are they at risk? Because they have a household contact who is diagnosed to have TB and probably undergoing treatment. Because of the pandemic, there has been many cases of infection becoming disease because of close contacts, longer period of exposure at home, okay? And then adults not getting treatment because of transportation concerns and other issues during the pandemic. So it's a single intradermal test wherein you administer 5 tuberculin units of purified protein derivative, okay? So we inject it intradermally until you create this wheel, this induration, this elevation because of what is being administered. That's correct one. Intradermal, almost 0-degree angle with the skin. And we use a tuberculin syringe. It is then read between 48 up to 72 hours from the time of injection. We look for the induration. It's something palpable. It's not erythema alone, okay? Erythema without any palpable induration on the skin is negative, is a 0 induration. Okay, so do not mistake induration with erythema. Although the induration could also be erythematous, but it is like a bump. It's something that you can feel, okay? In the absence of a bump or something that you feel, if it's just red, it's erythema, it's not a positive, it's not an induration. And we measure the induration. Okay? There are two interpretations of the test. A 5 millimeter or a 10 millimeter. This is a 10 millimeter induration. Okay, the widest diameter of the induration. Remember, beyond it is erythema, but it's not measured, only the induration. And we say 5 is positive if the patient has a confirmed exposure to an adult or an adolescent case of TB, bacteriologically confirmed probably, and the child has signs and symptoms, poor appetite, poor weight gain, cough, adenopathies. A 5 millimeter could be positive. 10 is considered positive for asymptomatic children who are simply screened for because of age or unknown exposure, okay? So the risk factors there include exposure, manifestations of signs and symptoms. Remember that a negative test may be false negative, especially if there is high index of suspicion because of factors. Why is my patient malnourished? That's possible to get a negative test. Oh, the patient received MMR vaccine a month ago, and therefore a recent live virus vaccination may give you a false negative test. Age of infant because of still the effect of BCG. All of this will be included in the assessment and interpretation of a possible false negative test. Or it could be due to the drug, to the tuberculin itself. It's expired. It was not put in the ref. It has been prepared more than 3 days ago and should have been used within 8 hours. So these are some of the factors. Or wrong interpretation. Okay. And so this is there is an updated one for the preventive pediatric healthcare given by the society, okay? And these are the screening factors, recommended age when to do that, okay? And some notes below. I think that's my last slide, unless you have some clarifications or questions. Okay, so are there questions or clarifications? So if none, okay, kindly stay for 4 minutes, okay? I'll just turn off my camera. Okay.